Great. Okay, so the topic of this PowerPoint is about the Alzheimer's disease mimics. But before I do that, let me do a quick introduction about that which we hold most important and the goals that, as I see it, everybody has their own goals, but these are the goals of the neuropathology core and what we do. The primary thing is to respect the research volunteers, which I think are the anchor and the guidepost for everything that we do. Second thing we want to do is defeat Alzheimer's disease and the dementias that manifest with the symptoms of Alzheimer's disease, which is a devastating disorder. One of the things that fires my career was my interaction with my grandmother, Tibby, my mom's mom, who passed away with Alzheimer's disease, and it was a very rough ride. And consequently, this is my mom, and I have the privilege of working just about every day to try to fight the disease that she is most scared of. One of the things that has caused most consternation, both for people who are at risk for the disease, such as my mom, and the people like me who fight the disease, is our so far lack of success in terms of finding a cure for Alzheimer's disease and associated dementias. The conversation that we're going to have today that I'm going to talk about is one of the reasons why there has been lack of success. And I think that some of the breakthroughs that we're having are going to be part of the story when we can actually finally start treating the disorder of Alzheimer's and the dementia clinical syndrome. So the main points of this PowerPoint is, number one, that Alzheimer's disease mimic conditions. These diseases are more common than most people think. An important Alzheimer's disease mimicking condition that I'm going to describe very briefly is termed late. And the third point is that differentiating late from Alzheimer's disease, or AD, will be a key step for developing therapies for treating both conditions. So those are sort of the overarching points. One of the things that's happened over the past 10 or 20 years that is, I think, very impactful and important for our field of dementia research is that there's a newly appreciated diversity of different diseases that cause human brain aging. It turns out that your brain is entitled to have more than one disease as you get older that impairs its function, that impairs memory, that impairs your ability to think and even to have good movements. And it used to be that there was this sort of curve. So here on the left, you see the prevalence, how common it is in a population. And on the bottom here, you see age. And at age 60, 1 or 2% of people have this dementia. And it was thought that basically all of dementia is the same. It was all Alzheimer's disease. And every 5 years, the prevalence doubles, so that 50% or more of people by the time you get to very advanced old age have this dementia, which was thought to all represent Alzheimer's disease. Well, it turns out that that is no longer thought to be true. There's a really revised reality here, which is shown on the bottom of your screen. And that is that as you get older and older, Alzheimer's becomes very prevalent and then levels off. And other conditions underlie a lot of the clinical symptoms of the dementia clinical syndrome. So that which we used to call Alzheimer's disease is now called dementia, because it's sort of understood that a lot of different disorders underlie in your brain the disease that contribute to Alzheimer's disease. So this is sort of how it looks like in a broader population. What about in an individual? When you think of Alzheimer's disease and dementia, you think of here your cognition on the left, your ability to think and remember. And over time, there's this relentless progressive disorder of thinking and remembering, and that was pure Alzheimer's disease leading to dementia. In fact, for an individual, it's now much better understood that that sort of constellation of events is actually fairly unusual. It's actually much more usual to have other contributing diseases that are contributing to the cognitive disorder. So what then exactly is Alzheimer's disease, and what do I do? Well, I help with the autopsies at the University of Kentucky Alzheimer's Disease Center, And what we do is we perform the brain autopsies. We chop the brain into little pieces, and then we look at those pieces under the microscope stained with specific stains that stain the features that are specific for different diseases. So when I look under the microscope of somebody who died with actual Alzheimer's disease, by definition, I see these two things. On the lower left, you see the brown blobs. These brown blobs are called amyloid plaques that stuff up the brain of people that have Alzheimer's disease. And this gloppy material called plaques are very important in terms of helping us to diagnose the disease. On the upper right, you see a separate structure, which is called a tau neurofibrillary tangle. These structures occur within neurons, the cells that communicate with each other in the brain. They stuff up the neurons, they kill the neurons, and actually it is the amount of this tau tangles in the brain that correlates very best with Alzheimer's disease. You guys may not know this, but in a previous life, Dr. Jicha, who's now a clinical person, used to be a neuropathology person, and he did some of the very coolest early work studying tau tangles in the brain. And he did some very important work with a very important group in New York. So these are tau tangles and plaques. This is what Alzheimer's disease is. But the upshot of this conversation that I want you to know that is a little bit encapsulated with a tongue-in-cheek way by showing this Dilbert cartoon is that it turns out it's actually very rare to only have Alzheimer's disease. In terms of advanced old age, it's very much more usual to have a combination of different diseases, and that makes clinical trials harder. It makes everything more challenging, and we're just now starting to grapple with the pathways that contribute to these other diseases, and I think that that's a critical point to enable us to go forward with a better hope of finding clinical therapeutic strategies for all of these disorders. So these AD mimicking conditions, which are basically the topic of this conversation, is that these have the same manifestations in terms of your life, your cognition, your memory, as Alzheimer's does. But they have different changes in the brain, they have different genetic risk factors, and they probably have different optimal therapies. Sort of analogous to if you have shortness of breath and you could either have asthma or pneumonia, the therapies for one are very different from the therapies for the other. And in fact, the therapies for one, if you give somebody something for asthma when they actually have pneumonia, it can make the pneumonia worse. So you really need to know that underlying diagnosis in order to have a chance at treating the disease. So this is a sort of a complicated chart, and I want everybody who wants to can ask us for the PowerPoint. You can look at it more carefully. The upshot of the next two slides is just to show you the difference between Alzheimer's disease and late. So this is the prevalence on the left. You here see the prevalence, the proportion of people in a population that have the disease. And on the bottom, you see the ages. As you go from left to right, it goes increased aging. And what happens is that Alzheimer's disease basically levels off and even decreases in advanced age. So these brown dots are Alzheimer's disease, whereas the green dots are late. In advanced old age, late pathology becomes more and more common. In terms of what late stands for, it's sort of a Greek alphabet soup. It's limbic predominant age-related TDP-43 encephalopathy, but I'm just going to call it late from here on out. And this is another chart that shows us essentially the same thing, looking at different data. On the left, you see the proportion of people with late at different ages. So from the bottom is a different age range. As you get into extreme old age, the proportion of people with late goes up and up and up. Whereas Alzheimer's, which is on the right, on the black bars, that actually goes up, but then actually decreases in advanced old age, which is a little bit different from cohort to cohort, but that's a very common finding. The upshot is that late is extremely common. It affects around 1/3 of people in advanced old age. And there's a very important contradistinction between late and Alzheimer's disease, is that all the studies so far have shown that late becomes increasingly common with every year of advanced old age. So 85, 90, 95-year-olds, these are the people that are at risk. Whereas Alzheimer's risk sort of goes up and then levels out at that advanced old age. So people with new memory problems in 90, 95-year-olds, that's very common, but it's most commonly seen with late than with Alzheimer's disease. So the upshot then of this point is that we thinking of a person that has just pure Alzheimer's disease and that drives dementia. But it turns out that what you actually see in the brains of really old people isn't that usually. It's usually a combination of different pathologies, of different brain changes. And they knock what Alzheimer's would do is complemented by what late would do, and then other diseases like vascular disease in your brain enable you to have your final actual trajectory, downward trajectory of cognition. So different things happen. So this is one more figure here that I'm going to show, and it's kind of complicated. It's a measure that combines both how common a disease is in a population and how impactful that same disease is in the same population for each individual. The upshot is this number right here, which is basically a single number that explains how much of the dementia in that population is due to a different disease. So here are 4 different extremely common brain diseases of aging. We have Alzheimer's disease, we have all vascular diseases like stroke and very much other different diseases that are related to interruption of blood supply to the brain. Here's late, and here's synucleinopathy, which include Parkinson's disease, dementia with Lewy bodies, and other Lewy body pathology. And it basically shows the hierarchy of the impact of the different subtypes of brain diseases, whereas Alzheimer's disease is very common and very impactful with a 39, vascular disease, all types of stroke, 25, late is about 17. So it shows you that late is not as impactful as Alzheimer's disease, but it's right up there and it's underappreciated and understudied. And so that it gives you an idea of the sense of the problem. And so it seems like a bad thing to discover that there are a lot of different bad things that happen in your brain. But in the first place, of course there are. So that's just the reality of the world. It seems like kind of a bummer to be a little bit analogous to something where somebody is jumping out of a building as shown by this old Far Side cartoon, and they are to be rescued only to be pitched into another building. In other words, there's multiple things that can go wrong, and that's kind of a downer. On the other hand, it really is a necessary step forward to figuring out how to cure dementia, is to grapple with this complexity, tease apart the different causes of the dementia syndrome, and then pick them off and develop clinical trial strategies for each one. In fact, recognizing late as a common brain disease will augment dementia research efforts in multiple ways. For one thing, it enables late clinical trials, and I believe that Dr. Jicha is going to talk a little bit about that. But in addition to that, it also enables significantly improved Alzheimer's disease clinical trials, because it enables us to have a basis to develop more appropriate cohorts for clinical trials with Alzheimer's disease that are not complicated by having late disease, which is a totally different cause of dementia, which is going to mess up the clinical trial. So it's a very, very important point. Much of the groundbreaking work that has ever been done on late was done right here at the University of Kentucky, and I'm going to just make a really quick point about that. It really has been a world-beating team here at University of Kentucky. We're a little bit used to that, but I don't think that most people understand the primacy and the respect that this place gets on the international stage of dementia research, which is a pretty big stage actually, because it's one of the top 5 killers of all human beings, and the University of Kentucky seriously leads the way. But it very much is, in fact, a team that is centered around the research volunteers. The research volunteers activity is absolutely central and a long-term benefit. The clinicians are strong, neuropathologists, radiologists, statisticians, geneticists. The leadership is strong, and bench researchers are constantly coming up with novel ideas that we can use to then get back into the research clinic as possible ways of therapeutically intervening to hopefully develop finally some sorts of cures or prevention for these horrible diseases of brain aging. So with that, in terms of talking about the team, I'll thank my team at the Neuropathology Core. It's a very outstanding team of people, and the center in general is run by Dr. Van Eldick. Dr. Jicha runs the whole clinical core, and a bunch of these other people do wonderful work, and we are really grateful every day to work with such an amazing group of experts. So with that, I will conclude, and thank you very much.